response from our COVID-19 Healthcare Coalition. We will be speaking about contact tracing today. We have a great lineup. Before we do that, I just want to mention a couple of housekeeping items. Next Friday, July 3rd, we will not have a webinar session, and we hope everyone gets a well-deserved break. When we return in July, on July 8th, we will commence with a every Wednesday webinar series. So at the same time, 2:30 to 3:30 on Wednesdays through July and August. And after that time, we'll see what the status of the pandemic is, and we'll continue to evolve our program together. So Susan, why don't you go back to the agenda? That'd be good. And I wanted to welcome, as we do each week, John and Jay to give us a little of their perspectives from Mayo and from MITRE. So John Halamka.
Well, thanks very much. And you know that every week I start off with this sort of rubric of as we go through COVID, we go from that isolation to testing to pre-vaccine return to work. You sort of ask yourself, well, how does our work progress? Because even though we are seeing these huge bumps in a number of states, you know, there is seemingly less of a focus on PPE and ventilators, that there's enough of those to go around, but it's very clear that testing and contact tracing are now the keywords of the week. And you probably saw that yesterday. Arizona is running into struggles of just the logistics of being able to test enough people. I know that I've been on multiple calls this week where reagents for the various testing modalities are in short supply, or if not the reagents themselves. How strange is this, FX? It turns out that to transfer a sample, you need a not nucleic acid containing pipette tip. And who knew that no one has a stockpile of non-nucleic acid containing pipette tips?
And put that on the list.
Yeah, right. And so what we're starting to see is that organizations that had capacity of 5,000 or 10,000 tests a day are now cranking back to 1,000 tests a day for lack of pipette tips. And so, you know, testing, huge focus. How do we ensure there are reagents and equipment, and we understand the sensitivity and specificity of each of these tests? My mom, right, almost 80, said, hey, one of her friends got this great lateral flow assay test on eBay, and it's negative, so let's all get together. And of course, I wrote her, let me explain sensitivity and specificity. And I actually sent her some documents from Mayo that review all of these tests that are on the marketplace and show that some of them have sensitivities of 10%. You know, far better to flip a coin than to buy this test. So that's, you know, this testing is a big issue. We'll hear today about contact tracing. Contact tracing takes so many forms, as we'll hear from our speakers. I've been on calls with Apple, Google, Amazon, Lincoln Labs, MITRE this week, as we all look at the different elements of that chain of identifying who to follow up on, how to do the follow-up, how to protect privacy, and talk about issues of what technologies should be used for what purpose. So very rich topic. And I'll tell you in my conversations this week, I'm sure our speakers will say this, this is not a solved problem, right? It isn't clear there's a silver bullet that will just be the contact tracing we could use in all localities and all purposes. So very much a work in progress. And then, you know, FX, the plasma issue, which is as we go with the pre-vaccine return to work, we're looking at cures. You know, will those cures be dexamethasone? You know, will it be famotidine and H2 blockers? Will it be convalescent plasma? Well, certainly we looked at safety, and convalescent plasma is safe. And a lot of studies are showing early indications for certain cohorts of population that it is efficacious. But what we are trying to do in the short term is just generate more supply. And so much of our efforts for many people on this call has been in working with academia and industry and government to align forces, build public awareness, build mechanisms of making it easy for donors to ensure that there is no donor left behind. That really is our effort. And There has been really a great uptake of the public awareness campaign, millions of hits on the website and millions of views of those videos. And we are talking about increasing the amount of funding and duration of that program so that we can reach more and more people. We're talking about mobile donor centers, arranging transportation, all the kinds of logistical things you would need to get as much donor plasma for convalescent plasma transfusion and hyperimmune globulin both over the course of the next couple of months. So that's been this week. Turn it over to Jay.
Thank you, John. I will just add one footnote to everything that John just said, and I'll be very, very brief. In addition to the themes that John has been talking about as being front and center this week, the other additional trajectory that I have been observing, and this is over a period of now of several weeks, and I believe it's a very, very good and positive thing, is increased and increasing interest by our colleagues and partners in the federal government, in various agencies, in the work that the coalition has been doing and trying to explore ways going into the future of working closer with either the coalition or coalition members. And we'll have more to say about this in the future, I'm sure, but this is a very positive thing. Although we had set up the coalition as a private sector initiated, membered, and driven organization exclusively, it was also temporary. And now as we think about how do we have enduring and continuous and sustainable impact as this problem continues into the weeks and months and perhaps even years ahead, can't be with a temporary stand-up coalition. There have to be more permanent entities and arrangements, and certainly docking some of our work to the federal government at some point would make a huge, huge amount of sense. And if I were to pick one where it would make extraordinary sense to have government engagement at multiple levels, federal, state, regional, municipal, and so forth, it would be all around contact tracing. So I think the topic today fits very nicely with that future theme, and I would encourage people to be thinking about that as well. And I know that many of the folks on the panel today and behind them have already been thinking about that. So with that, I will turn it back to FX to guide us through this important conversation today. Thank you.
Thank you, John, and thank you, Jay. And again, thank the two of you for your foresight in putting together the coalition. The fact that the coalition has just over 1,000 member organizations is testament to the fact that we have a lot of goodwill and a lot of innovation working on the pandemic day and night. And the topic of contact tracing, as you said, is really an important synthesis of all of these sectors. And so we're going to hear stories from 3 organizations today, from Google, then from Partners in Health, and then from MITRE. And you're going to hear different facets of the stories that relate to contact tracing. It's quite possible that we'll have another webinar session later in the summer on the same topic, because it's such an evolving area, and it's such an important and necessary area for the return to work and the continuance of our society during the pandemic as it evolves. So with that, I'm going to ask Wendy K. Logan from Google to give a presentation about what they've been up to, and her colleague Travis Beals will be also part of the discussion panel. After that, we'll have Shefali Oza from Partners in Health, followed by Dr. Paul Jarris, and then our work group leader, Rakhi Palakar, who's been guiding quite a group through the contact tracing story over the last 8 weeks or so, and she'll help to position some of the question and answer that we'll go with. We'll finish our Q&A with about 10 minutes to go in the hour, so right around 20 after 3, and we're going to have a brief presentation from Noah Scheinbaum from U.S. Civilian Corps. He's going to be telling us about a really innovative project they have to help continue to move talent where it needs to get to during the pandemic through their trusted human capital service base. So thank you. Let's go ahead with Wendy K. Logan from Google.
Great, and thanks everyone for the opportunity to walk through this. So what we wanted to talk about is the Apple, Google exposure notification system. So what exposure notifications are the alerts that people would get on their mobile phones, letting them know that they have been exposed with someone who is diagnosed with COVID-19. This solution is meant to be a supporting role or another tool in public health's toolbox to support the broader contact tracing efforts. It's not meant to be a replacement. And when we built this solution, we always kept privacy at the core. So it's using non-identifiable Bluetooth signals and detecting proximity versus using anything that would detect anyone's specific location. So we don't use GPS, we don't use any location data. Why? Because we really care about people's privacy as it's key to building user trust and user adoption of the system. In addition, the system is configurable by public health authorities since they are in the lead here. And things such as what does a meaningful exposure mean? Is it 15 minutes at 6 feet? All of those kinds of things and criteria can be adjusted along as the recommendation to those who have been exposed. Should they go get tested? Should they self-quarantine? All of those recommendations are configurable by public health. And beyond the fact that Apple and Google want to be helpful given this global moment, there are other reasons why we've gotten involved. One, there are inherent challenges of traditional contact tracing, such as resourcing, especially during a surge. It takes time to hire and train the sufficient contact tracers to follow up on the need. Also, speed is of the essence with this specific virus, and there's people who won't pick up phone calls from the phone numbers they don't recognize. Also, just the time to track down and the appropriate contact information and make contact takes time. And then finally, for those that we are able to contact, there's an issue of completeness. Not only remembering those they have been in contact with, but also strangers, right? People wouldn't know the contact information for strangers that they've been in touch with. So what we saw globally is that public health authorities like Singapore, like others, organically decided what can we do with mobile phones to help address these challenges. But because the most popular mobile phone operating systems, so specifically Android and iOS, were never intended for this use case, there were some technical challenges they had to overcome, such as not being able to perpetually broadcast and scan Bluetooth for the sake of protecting battery life. Those are things that were challenging, and then also cross-platform compatibility. So by Apple and Google making some APIs and changes at the OS level, we're able to make this most useful for this moment, and then help address and help supplement traditional contact tracing efforts. But just to really spend a bit more time on privacy, I want to really focus on the things the key principles that we made true in this solution. One, everything is user control. So users explicitly consent to opt into the service and can turn it off at any time. Same thing with users who want to report that they've been tested positive and upload their diagnosis keys. That is also optional for users to choose. Second, as I briefly mentioned, it's privacy by design. We're not using location information. We're not using GPS. And also, we're not collecting any personal identifiable information as part of the app. Therefore, Google and Apple won't have information about users. And then finally, this is COVID-19 focused and really meant for this moment and only this moment. We're not using it for any commercial purposes. It's really for the good of the public and public health. So once this moment is over, we will shut down the system with the advice of public health based on where we're at in the pandemic. But that is the intent of the solution. Now let's walk through what this could look and feel like. So let's take Alice and Bob. They're strangers, but they happen to get into a lengthy conversation on a park bench. In the midst of that conversation, their phones are anonymously exchanging Bluetooth keys that change every 10 to 15 minutes to avoid the ability for an external party to track those keys. But a few minutes later, a few days later, after that conversation's over, Bob unfortunately is diagnosed with COVID-19 and gets that information from his public health authority. In the app that the public health authority builds, he opts in to report himself positive and upload to a temporary storage, which is what you're seeing at the bottom right, the keys that he had been broadcasting during the time he was infectious. So he uploads those keys to that temporary storage. Meanwhile, Alice goes about her day, unaware that Bob has tested positive and that she was exposed. But in the background, her phone is periodically pinging that temporary storage to see, has that phone come into proximity with any of these keys affiliated or associated with those who have tested positive and what they were broadcasting while they were positive. And because she was in proximity to Bob, her phone finds a match, and as a result notifies her that she's been exposed, and then alerts her with her next step as determined by her public health authority, whether that be to test or to self-quarantine. Now, stepping back, how this ties to broader contact tracing, let me walk you through that. So the top left of this box is Alice and Bob's phone that's perpetually broadcasting and scanning Bluetooth keys. The center is the app that will be on their phone where they can interact, either get notified that they've been exposed or for Bob to report that he's been positive and upload his keys. So let's, for instance, say Bob's using the app and then he gets a call from a case investigator or contact tracer to say that he's tested positive. What he can then do is optionally in the app decide to report himself positive. What will then happen is that his temporary exposure keys, a hash version of that temporary exposure key, then gets sent to this green box at the bottom, which is the test verification system. What we're seeing in most states is that most states want to be able to validate that Bob has tested positive, but you also have options to do self-verification and other options. But in this case, let's assume his state wants to give him a unique single-use verification code. So that's what the contact tracer would tell to Bob during that conversation. Bob would enter that PIN into the app. It would then upload that PIN plus a hash of his temporary exposure keys to the test verification system. It would make sure that the PIN was valid, and if it was, it would send a verification certificate back to the app. At that point, now that his test is positive and it's verified by public health, that app would then send those temporary exposure keys back to the key server, which is that yellow box on the left. And so that was the temporary storage that I was talking about earlier. So that server is temporary. It's holding all of the positive exposure keys associated with those who have tested positive and what they were broadcasting while they were infectious. And it's really key, especially in the US, for that to be done at a national level, because that helps solve the case for people traveling across state lines, which is very, of course, common in the tri-state region and just generally common as we get back to a new normal. And so that's how that system works. And it's really important too that we've designed the system again with another privacy and security concept in mind, is to separate those two. So have the key server separate from the verification system so that there isn't any chance of collusion between that information and being able to re-identify who's tested positive. So that is impossible with this design. So now going into the right-hand side, how do we tie back into traditional contact tracing? So the same app is the app that Alice would get a notification on saying that she's been exposed to someone who tested positive. In that moment, public health can also ask for Alice to optionally give additional information about herself, whether that be her phone number, her zip code, etc. And that information can be saved in the state's contact tracing CRM. And that could be used for additional analytics to say where are the hotspots based on zip codes. It could be used for symptom tracking, it could be used for additional customized follow-up, and that's what case investigators and contact tracers and other apps can also plug into as well. And the last bit I wanted to leave you with is, I know many of you may have heard about the quote about 60% adoption is the minimum for this to be effective. And where that's coming from is actually a misunderstanding of some stats that were done by the Oxford University Research Group, showing what's needed for this to be helpful. The main takeaway from that analysis is actually exposure notification apps can slow the spread at any level of adoption. And what you're seeing here is post-lockdown, after everyone starts kind of releasing their lockdown measures, it still assumes that people are still doing a bit of social distancing, but at any point in any adoption level, it actually still is helpful for the broader community. And specifically in that case study, it said that for every 1 to 2 app downloads, it actually saves an infection, or it eliminates one infection. So if you use the just general assumptions of 1% fatality rate, what that really means then is every 100 to 200 app downloads saves a life. So really that is kind of what I want to leave you with here is that, of course, we want to make sure that as many people adopt, but at any level, it's going to be helpful. And it's better than potentially not doing anything. And so that is potentially a helpful additional tool in the toolkit. So with that, I'll leave it at that, hand it off to the next presenter, and then we'll come back for Q&A.
Great. Well, thank you very much, Wendy K. That's great. And there's a bunch of questions in the chat, and I think they're going to be particularly helpful as we move into the Q&A. So we're going to hold on to those, but there's some questions around the technical aspects, also about some of the permissioning related to it. Great presentation. Thank you. We're going to now ask Shefali Oza from Partners in Health to give a presentation about their work in developing and expanding contact tracing across in many jurisdictions in the U.S. Shefali comes to Partners in Health from her work in London at the London School of Hygiene, and she's also been involved with Médecins Sans Frontières over the last many years. So Shefali, thanks for joining the fight here, and please go ahead with your presentation.
Great, thank you. And thank you for inviting me to be a panelist today. I apologize that I don't have a presentation, but I will walk you through the work we're doing right now. So I'm an epidemiologist working with Partners in Health as part of the Massachusetts kind of effort. And this is, Massachusetts has a statewide effort, I think as many of you know, called the Community Tracing Collaborative. And this is an attempt to have a statewide contact tracing system. And so I'm working with Partners in Health and various partners, both in government, including the Department of Public Health, the local boards of health, tech companies, to kind of create a system for contact tracing across Massachusetts. And that's what I'll speak to right now. So I think probably this audience is pretty well aware of how contact tracing is a key part of the public health toolkit for getting an epidemic down, to try to stop things, diseases from surging, and then as they're coming down, to kind of get them under control. And the question that has been difficult to answer, I think, for all of us has been how to take something that is done by public health departments in all states across the world for diseases, for a number of diseases, and how to set it up for the scale and scope of this pandemic, and how to do that in a way that integrates into the existing public health infrastructure. So what Partners in Health has been working on with our partners is to develop a system where we can mobilize a large workforce to perform the activities of contact tracing. And I can walk you through a little bit of what we do, kind of a day in the life of the contact tracing program. So we have a large workforce, up to 1,500 case investigators and contact tracers. We have a system that is the CRM, which is the database that we're collecting information into. It's a Salesforce platform built by Accenture, and we work very closely with the Department of Public Health to have a kind of two-way communication between Massachusetts surveillance database, which is called Maven, and how it integrates into the system we've built, the CRM. And so when a confirmed case comes into our database from Maven, we have case investigators who will call the case, talk to them about COVID, about whether they're receiving care, kind of a full case investigation and interview into things specific about what they're facing with their diagnosis, but then also collecting their close contacts. And we also have a system to provide a home assessment is done. And if the person needs any additional assistance, then they're linked to care resource coordinators in our workforce. And these care resource coordinators are able to connect them to, connect the case to local resources that can help them safely self-quarantine and isolate. And I'll talk more about that in a minute, because I think it's one of the most important ways to have contact tracing be an effective method, especially in a pandemic of this size, and with the kind of consequences people are facing in their lives because of it. In addition, we call the contacts of these cases and we advise them to quarantine, and we do a similar interview to assess whether they need any assistance in being able to safely isolate and quarantine. We also follow them during their isolation and quarantine period. And this means that for cases who have been diagnosed with COVID, we call them every day to make sure they're doing okay, to find out if they have any new symptoms, if they're linking into the care they need, if there are any additional resources they need, just a general check-in throughout their isolation period. And for contacts, we would call them every other day. And throughout this period, anyone who needs assistance beyond that sort of check-in call, we again refer to these care resource coordinators. So one thing about this model that we've been trying to really push hard is this idea of how to do this in a way that can build trust and support for the people that we contact, and in general the community, and so that if and when they do receive a call, they can trust that we are there to support them and that this is a human-centered approach. So one thing we've been saying is that this program is kind of human-driven and tech-enabled, and we have various things we do to try to make sure that that's one of the main strategies we drive towards. So for example, we are doing phone calls for follow-up. We want to make sure that we have this human contact. We want we want kind of public health priorities to be driving the tech, and public health needs to be driving the tech. And so we have been working with tech partners, and we've been evaluating various tech, but always with the lens of how it fits into this kind of human-centered effort, and also how it can support how it can integrate into the existing public health infrastructure. Another thing that we're really trying to focus on is the equity lens. As we know, this pandemic, along with this pandemic is affecting different people in different ways, and in public health in general, an equity lens is always important. And it's been highlighted kind of throughout how important an equity lens to everything we're doing is, all the way from making sure that we are able to reach everyone. We're able to reach communities where they may not want outreach, they may not trust outreach from government or public health authorities, and how we can kind of build that trust into the system. So, and this is not just Partners in Health, this is the entire Community Tracing Collaborative working really hard on how to engage community leaders, how to have town halls to make sure that communities that are at most risk in this pandemic, and in general because of their lack of access to social safety nets, are actively being reached out to, where this is where the contact tracing effort is not something that where we're very careful rather about how to kind of talk about the contact tracing effort and what it means for an entire community, or in fact the country and the world in this case, to have to try to follow public health measures that can reduce the pandemic during this time. And so I can talk a lot more about this during the question time if people are interested in the sorts of things we're trying to do to build trust. In a kind of day-to-day, as we set up the systems, a lot of what we're doing right now is trying to collaborate with government and local partners, the local boards of health in Massachusetts, working on the system design and how the system we have in place right now, the database, can meet the needs of contact tracing for the level we have right now, but also in preparation for any kind of surge that we think may be coming as another wave hits us. Thinking very carefully about the metrics and the data that will help us both measure and evaluate the program and how the program can be improved, what kind of gaps we can be addressing, and also whether any of that information can tell us about where we are in the epidemic. And again, for Massachusetts, it's MAVEN, the surveillance system, so through the Department of Public Health, that is kind of the holder of, is the source of record for public health information. And so questions on how our information can integrate into that sort of system. And these are questions being asked across all the different states and across different countries right now. It's a new virus, and creating a contact tracing program at this scale means that there are a lot of protocols that are getting written almost from scratch, not on the foundations of what contact tracing is, but how it applies when, instead of going door to door or having this be kind of a localized investigation, you're doing it at a massive scale through a call center, for example. The kind of the public health protocols, the workforce protocols, the trainings, and how you train a workforce that's quite diverse in their background. A lot of the workforce comes from a public health background, but a lot of them also don't. And so how to kind of get that system into place. We started in early April. I've lost all track of time, but we're still, I think we've made a lot of progress, but there's a long way to go. And I think ultimately the questions are, in my mind, how to have this be something that works really well with the existing public health infrastructure, and always with the view towards kind of making the public health infrastructure in the US stronger across the world. My background is actually global health, but including in the US, how to make the public health infrastructure stronger, and how to have a nimble response to this. Because I think none of us think it's over anytime soon. So I'll stop there. I hope that was semi-coherent.
Fantastic. Well, thanks so much. You hit on a lot of important points. I think the trust factor is going to continue to resonate as a key component of any successful program, and it could be one of the biggest challenges, despite great technology. So we're going to come back to that. We're going to ask Paul Jarris now to present. He's going to be giving us an update regarding Sarah Alert. You heard about Sarah Alert about 6 weeks ago. Kathy Feldman from Paul's team gave a brief presentation on it, and in that short time, it's you guys have moved a few mountains already, and I know there's a long way to go. So thank you, Paul, and we look forward to your presentation.
Thank you. Can you confirm that you see my screen?
We can see all your slides on the runner as well. If you want to go to presentation mode, either's fine though.
I actually thought I had. I apologize. Let me get to that now. Let's see if does that work for you, FX? Okay, so let me thank you, FX, and to the coalition for providing the opportunity to present today. A couple things to point out. Wendy Kay had talked about the Apple-Google proximity notification, which we sort of look at that as stranger notification, if you will, or people that you don't know you may have been in proximity to. Sarah Alert was really built together with public health professionals, associations, and organizations to reflect the flow of how epidemiologists do contact tracing, but also importantly, how they actively monitor and support people who are contacts in quarantine or who are ill in isolation. So we like to say it was sort of built with public health for public health. So it is not an app to be downloaded on the phone. We did not think foreign nationals coming into the country would like to do that. It is a web-based tool that is hosted on what's called the APHL AIMS platform. This is really the premier public health platform out there that all 50 states, the DC and the Office of National, 50 states, the CDC and the Office of National Coordinator are using. So we built this, of course, hoping, because we knew we needed a tool at the outset of an outbreak, and we did not have one. I was a health commissioner in the state of Vermont back in 2003 when we had the original SARS outbreak, and have been involved in every outbreak since then. And frankly, we have never had a tool to stand up day one of a pandemic. The two tools that were built in Georgia and Maryland for Ebola were built specific to that disease, and therefore could not be stood up for a new disease. We also want something at the border for an outbreak that occurs overseas, or if a new wave occurs overseas. At the time we began this, the federal government wasn't ready to work at the border yet, but we are beginning those conversations now with global quarantine. In addition, there are parts of the country that don't have widespread community outbreak right now, and the tool has utility there in preventing widespread community outbreak. What we're seeing across the country with relaxing of social distancing are brush fires breaking out. We expected a rebound, and we want to be able to have a tool to put those brush fires out before we have a forest fire again with widespread community outbreak. And then, of course, it's only prudent to plan for future waves, whether they begin in this country or overseas, and get the tool in place so that we can meet head on any future waves. So a little bit more about public health. Public health is federated in this government, in this country. Constitutionally, the police powers of public health fall to states, not the federal government. Having said that, we did know, and we met and worked with CDC, Assistant Secretary of Preparedness Response, Department of Defense, Veterans Affairs, Homeland Security, and many others at the federal level to have them aware, since many of them have an engagement with public health. In addition, we have engaged with private sector players like the Gates Foundation, having conversations with IBM Watson, Salesforce, Optum, Google, and then multiple private vendors who support the states, because as a not-for-profit, we want anyone and everybody to use this tool, whether they build it into their own proprietary product or people use it as an open source tool that we have developed it. The tool is available to governmental public health organizations free of charge to anybody else as an open source tool. Stefali talked about how important it is to work with the public health organizations. From day one, when we started whiteboarding, we had local health officials embedded in the teams and have continued to work with the Association of State and Territorial Health Officials, which are the health secretaries and commissioners across the 50 states, DC, and the U.S. territories, and I ran that organization for 10 years before coming to MITRE. Very important group in adopting at the state and territorial level. The Council of State and Territorial Epidemiologists are the epidemiologists throughout the nation who actually set the case criteria that CDC uses. They're involved with us very closely. The National Association of City and County Health Officials, who do your regional, county, local health departments, and of course CDC and the CDC Foundation. So we meet every other week with the CEOs of these organizations and closely involve them in developing the tool to go forward. When we began the tool, our goal was eventually to initially have a state, a territory, a tribal, and a local health agency begin. And fortunately, we've been successful in achieving that. Very briefly, the way SARA Alert works is someone enrolls an individual. They can be manually enrolled.
Well, you need to advance your slide, I think.
Excuse me?
You need to advance your slide, perhaps?
Has it not advanced for you?
No.
How about that?
We're still seeing.
Are you on the SARA Alert workflow, or which side do you see?
I'm still seeing the first slide.
Oh, geez. Okay, I'm just going to go. Tell me if. Do you see a slide? The second slide.
Yeah, number 2.
Okay, 3. I'm now into this. I apologize. We can make these available to you.
There we go.
If somebody is exposed or sick, they can be enrolled directly into SARA Alert. We can import from other tools such as Maven or NEDS-based systems or RedCap, or essentially any other tool people are using. And then we have an HL7 Fire API to also enhance a standards-based way of interacting with SARA Alert. We can credential enrollers who then speak to the person, ask them if they would like to report their daily symptoms via the web or smartphone or tablet, via email, via their text messaging or phone calls, and phone calls can go out to landlines or cell phones so that we can get people without smartphones or without even a mobile phone. They report in on the daily self-report based on CDC criteria. That is encrypted in motion, encrypted at rest. We don't have time to go into the security built into the system, but then it divides it into what are called line lists, which is what epidemiologists work over. So for exposure modification, or you might say quarantine for people who have been exposed, the line lists include a symptomatic line list. That will be the highest priority for the epi. Contact the person, verify their symptoms, and if need be, they can order testing or clinical care, and the person becomes a person under investigation. For non-reporting, in some cases, this carries the force of law that people are quarantined. We can find out if they lost their cell phone or if they need help. One of the powers of SARA Alert is that we're estimating 50 to 75% of people who have been contacted will not develop symptoms. SARA Alert will ping them every day. They'll report no symptoms and go through that cycle for 14 days. So we can remove up to 50 to 75% of the outreach that a health agency has to do, so they can focus their very scarce resources on those who are symptomatic or non-reporting and need it. I won't go fully into the isolation monitoring for people who are cases, but we do have the ability to monitor people in isolation if they meet a recovery definition, and there are 3 recovery definitions that the CDC has established. The EPI is notified of that on their line list. They can confirm someone has met a recovery definition and release them to the community. And again, that often has the force of law in some communities. The third thing here is that the data from this in a de-identified, aggregated fashion is made available to decision makers so that they can track the outbreak. I wish I had time to go into more, but we'll be quick. Here's where we are as of yesterday. As you can see here, we have a number of states. Importantly, we have both centralized states where the locals are part of the state, but we also have what are called decentralized or home rule states where the locals and state agencies are separate, which adds a great level of complexity. We have major metro areas, Kansas City here we're working with, both in Missouri and Kansas, and we have major metro areas in these other jurisdictions. Tribally, we have the Great Lakes Intertribal Council working with Native Americans, tribal organizations. We have territories both in Puerto Rico and the Commonwealth of Northern Mariana Islands. And interesting, we also now have a vendor working with Marshall Islands using the open source data on their open source system on their own instance to stand up. So we feel like we're getting the bases covered to understand how to implement this in a wide variety of settings. We're seeing usage increase fairly consistently, so that we have about 40,000 monitorees that have been monitored at this point, 28% increase in the prior week. And as states like Pennsylvania, Washington State with larger populations are coming on, this is increasing quite a bit. We've trained over 3,000 public health users in the jurisdictions who are using the tool right now, and about 472 sub-jurisdictions and 14 major jurisdictions, so about 500 jurisdictions using it. We do use agile development, and so we have every other week we release an update, and we are continually working with the users to define new features such as Spanish language, Puerto Rican Spanish, Somali, and many other languages that are built with them, so they reflect the dialect and reading level as appropriate to their community. If any further information, you can email Sarah Alert or look at saralert.org or email us a question. We have a really neat video we just released on YouTube. You're welcome to look at that also. So FX, I'll end it there. And happy to move to questions when we're...
Great. Well, thank you. And I'll just ask all the panelists to turn on their cameras. We have about four or 5 minutes for questions, and then we'll break to go to our colleague who's going to make a presentation on U.S. Civilian Corps. So thank you. There's a lot of Q&A going on in the chat. I just wanted to ask Raki Pelikar, who's been our work group lead for contact tracing, if she has any other comments, or maybe just remind us about the work of the coalition in this area.
Thanks so much, FX. So I'll just be very brief and just maybe take a minute and talk about what we've been thinking about in the contact tracing working group. And I first just want to thank all of the panelists and colleagues for presenting about the exceptional work that they're all doing in this area and highlighting this idea that there really is no one solution to this complicated problem that we're facing, but rather we need to find a way to bring different types of solutions together. So in the working group, we've been thinking a lot about this over the last 4 weeks or so since we started meeting. And I maybe will just drill down on 3 specific ideas that we've been talking about. So the first is, I think we're all aware of the fact that there are a multitude of digital solutions that are flooding the market. And so I think we really need to think about how can we make tools that are interoperable and establish standards to facilitate this interoperability. And I think this is especially important. I think we'll all know that in the public health world, there's a long history of limited funding going into public health to support technology, to support information systems, and to support interoperability. So this is really of paramount importance. The second issue we've been talking a lot about is how do we effectively bring new stakeholders into this space. Previously, contact tracing was really a job for public health 100%, but we've seen certainly with this pandemic that there's a lot of interest from employers, from universities, from others to support this contact tracing process, which is fantastic, but we need to ensure that we're working synergistically and not creating any confusion for the public. And then finally, as we've seen, this pandemic really has had a disproportionate impact on vulnerable populations. And so as we think about the different solutions, that we're putting forward, especially the digital side, how do we support lower income populations that might not have access to different types of to different types of technology that are needed to support the utilization of these different tools? How do we support those that have poor digital literacy, for example? And then for folks that have access to technology and are comfortable utilizing technology, but are still uncomfortable or untrusting of these technology solutions that we're putting forth, how do we work with them? And so we've been talking a lot about all of these topics within the working group. And so I'll maybe pause there and hope that we'll have some time to dive into some of these topics. Thanks, FX.
Thank you. I think there are certainly questions about the technical aspects of the exposure apps that have been mentioned, and some of those have been answered through the chat. I guess one of my overriding questions is, how do we interface the public health processes with any private programs. A lot of employers are doing organized back to work questionnaires and automated processes that may include even testing at the work site. So I just wonder if any of the panelists could comment about that, or whether we see any best practices. How are those handoffs created between the public and private spheres?
Yeah, I would suggest that for an employer that's looking at their return to work, that they do make a call or speak to their local or state health agency to talk exactly about that. For someone who is a healthcare provider and is licensed, it's actually mandatory that they report to the state. That is usually done through the laboratory. Sometimes it's done clinically or through the electronic health record. That may or may not be true for an employer, but if the employer does have licensed occupational nurses, they are an obligatory reporter. So it's good to know that side of it. But if you are aware of a positive, someone who is positive, it would be very valuable to let your local or state health department know about that. And there may also be responsibilities for the employer to notify other coworkers who may have been exposed.
Right. And Wendy Kay and Travis Beal from Google, I'm wondering, there was a question about who can use the API that's been developed that you demonstrated. Is it only through a public health authority app, or can that be adopted through private apps, so to speak?
The app has to be built under the authority of a public health agency, so at the state level in the United States. But then you could have private entities, employers, universities, and so on, encouraging their members to adopt the app and to use the app. So we do want to recognize that public health needs to lead in this space, but there's opportunities for them to partner with entities.
That's great. Thank you. And just, I wanted to get back to Shefali about the trust factor. When you think about, the 2 or 3 things that are the most important for building trust in any of these programs, how would you rank those? What's number 1 on your list?
Across any sort of how to build trust across these?
For these contact tracing efforts?
I think a lot of transparency. And so 1 is transparency, 2 is how the program is described, even to the point that there's been a lot of discussion around the words tracing and the words isolation and what these mean when you're trying to encourage people to do something that is a public good through something like a public health authority or a government-based program, and being careful about how the word surveillance is used, because epidemiologists say disease surveillance, but surveillance means a very different thing to different communities across the country. So I think the way we discuss it, transparency, and then I would say the type of community outreach needed across whatever technology is used, whether it's the kind of program we're doing or not, though communities have to understand what is being delivered and why it is an important public good to participate. And so community leaders and all sorts of groups in civil society, I think, need to play a role and be stakeholders in it.
That's great. Well, thank you very much. And thank you to all the panelists. We will continue with the story of contact tracing. We're going to hear about it more through many of our future conversations this summer. On July 8th, we'll be presenting a panel group on back to universities. So how do we get students back into a university setting and faculty? And I'm sure there's going to be elements of contact tracing discussed there. But right now we're going to break and invite Noah Scheinbaum from the U.S. Civilian Corps to tell us about a request they have to the coalition regarding their new program called the Trusted Human Capital Service Place. So Noah.
Thank you, Dr. Campion. It's really appreciate that. It's wonderful to be with everybody. Thanks for a few minutes of your time. It was great listening to this panel. I'm really supportive of the work that you all are doing, and just thank you for everything you're doing. I know contact tracing in particular continues to be excruciatingly difficult, but it's also a key to getting open and staying open. So very briefly, I'm Noah Scheinbaum. I'm one of the co-founders of an organization called the United States Civilian Corps, or USCC for short. We're a 501c3 nonprofit that is focused on the mission of getting more Americans engaged in public service. I'm actually going to try to share my screen real quick. Let me know if you can see it. No, that doesn't seem.
There it is.
There you go. You able to see?
We got it.
Wonderful. So our goal is about service. During the last few months, during COVID-19, this has meant focusing specifically on the human elements of this pandemic challenge. And so our experience started by just wanting to bring surge human capital to the point of need, responding as states around the country said, please show up if you're a medical professional. We, through a database of about 12 million licensed medical providers nationwide, we're able to target those individuals and point them to the places that needed their assistance. But then we found out that going through states was often kind of cumbersome, and the policies, the processes, and the apparati were not in place to deploy those folks rapidly. So we evolved to surge resources faster. And we helped working with organizations such as the U.S. Digital Response, a group of technology volunteers, to create processes that would more seamlessly match both volunteers and individuals who are furloughed or looking for work, but who could be useful, and to get them matched with health facilities and of all kinds much quicker. And then, as we've evolved, we've listened from health systems, from hospitals, from long-term care facilities who talked about being overwhelmed by the outpouring of support they received during this crisis. And so today are focused on surging the right resources to the point of need as fast as we can. It is tempting to look past it was, I should say, tempting to look past COVID up until a couple of weeks ago. I know it's not an issue for this group, but many were focusing on reopening. We at the Civilian Corps were focused on how do we institutionalize the gains and the lessons of the last few months, so that in the event of a second wave, which unfortunately seems to be upon us far sooner than certainly than we would have hoped, how do we turn the apparatus back on and allow these human capital resources to get to their point of need immediately? And so we are working on today a software platform that, as Dr. Campion said, we call a trusted human capital service place. What does this mean? It means creating systems that are built for the HR executive, the user at a hospital, at a long-term care facility, that closely mirror the workflows that individuals need to be able to meet their human capital demands. Rather than just sending Excel lists of volunteers or Excel lists of potential resources, we want to build a system that effectively brings this two-sided marketplace together and puts these volunteers or these surge resources in the hands of HR professionals, pre-vetted, license checked, background checked, and ready to deploy with all of the information that you would need to make a resourcing decision in real time. And so the ask, as Dr. Campion alluded to, with this is a software platform that is in active development. We have been incredibly fortunate. The outpouring of private sector support in this initiative. We have an entire kind of pro bono development team working on this. We have user researchers working on this. Our goal is to get this into production in the next couple of weeks. This is not an academic exercise. We want this to be of use immediately, as quickly as possible. So if you are a health system, if you are a hospital, if you are a long-term care facility, and you have a few minutes of time to talk about how this can be more useful to you and what resources you need to be able to meet the real or projected demands of COVID-19, please reach out. My email is here on the slide, but I can send out or I'll put it in the chat as well, and maybe follow up in the next kind of email to the group. We want to talk to you. Just even a few minutes of your time would be hugely valuable and help us make this a resource that can be useful to you all in trying to make a difference in our COVID response. So thank you very much.
And I think your story about creating this on the fly is a all too familiar story, and just what we heard about the contact tracing apps as well. So we are learning a lot collectively, and we are all the better for it. So I just encourage everyone to continue the fight and continue to rally. Thank you for spending your Friday afternoon with us, and we look forward to seeing all of you back on Wednesday, July 8th at 2:30 for our next presentation, which will be on universities back to school with COVID-19. Thank you all. Have a safe weekend.